quickly on this. Again, my name is Dr. Deshira Wallace. I'm assistant professor in the Department of Health Behavior at the Gilling School of Global Public Health at UNC Chapel Hill. And I'm happy to, hello, Dr. Chapel. I'm happy to introduce our great panel today. So first we have Dr. Debra Furr-Holden, who is a professor of epidemiology and biostatistics at Michigan State University. And at Michigan State, Dr. Furr-Holden is also the Associate Dean for Public Health Integration and Director of the Flint Center for Health Equity Solutions. Her work has always centered on health disparities and health equity in research and in working alongside with local and national policymakers to improve data-driven decision-making across a range of health topics that require equity in its policies. And this was also relevant throughout the COVID pandemic, where Dr. Furr-Holden was appointed to government task forces to address public health needs throughout Michigan and other states and cities in the United States. We also have Dr. Theresa Chapple Magruder, who is the director of Oak Park Department of Public Health in Oak Park, Illinois. Dr. Chapple has been working in applied public health before and throughout the pandemic, while also translating epidemiology of the pandemic to broad audiences on social and mass media. She has advocated for this nuanced understanding of research on COVID in relation to schools and engaged directly with school districts to help them develop safety plans. To that end, Dr. Chapple centers anti-racism and an anti-oppression lens in all of her work. We also have Dr. Stella Safo, who is a board certified HIV primary care physician and assistant professor of medicine at Mount Sinai. Dr. Safo is the founder of Just Equity for Health, which aims to improve healthcare by reimagining the delivery of equitable care and uses advocacy, education, and care models to design to target racism and sexism that harm Black people and people of color in community, as patients, and as healthcare providers and healthcare practitioners. We are delighted to have Drs. Chapple, Furr-Holden, and Safo participating in today's conversation. And so to get started, I want to make sure everybody in the room has the same frame of reference as we have these conversations. And I want to kind of get started with a couple definitions. We're probably going to hear the term racism, so I wanted to give a definition of racism as a foundation. So using Dr. Ruth Wilson Gilmore's definition of racism as a state-sanctioned and/or extra-legal production and exploitation of group differentiated vulnerability to premature death. The reason I like this definition is that it showcases how racism is engineered and its function is to primarily to not allow groups that are discriminated against to thrive and much less be healthy. So we're in a panel filled with public health individuals and practitioners and professionals. And when we are talking about the pandemic, we've heard the term public health for the past 2 going on 3 years. And often I find that it's not really public health that they're talking about. And so I wanted to hear about from you all, what is public health and what is public health function? And we could start with Dr. Chapple.
This is probably one of my favorite things to talk about, because I think that public health is really misunderstood kind of across the board. So when I talk about public health, I talk about it from a governmental kind of standpoint. And governmental public health has 3 roles. One is that we need to promote good health in our communities. We need to prevent diseases, prevent as much and all diseases as possible. And then we need to protect the community's health. And we do that through public health laws, public health code, public health, governmental public health pretty much touches all aspects of our lives, down to restaurant safety and where we eat and making sure that food is good, all the way through vaccine mandates. This is something that is not new to governmental public health with COVID. Vaccine mandates are something that we all are used to encountering in our lives. If we think about what's necessary in order to have our children start kindergarten, what's necessary in order to go to college. So governmental public health really has a role, and the role is to protect and promote the health of the community in which we serve. There is a quote that says that the number one concern of a state should be the health and well-being of its people. And that's really where public health fits in, and what it is that we do.
Lovely. I agree with that. Dr. Safo, do you have any additional?
I love Dr. Chapple's outlining of it. And I think the one thing that I would add is that we have to consider ourselves to live in a world where we touch each other collectively. And so if you think about healthcare access that most of us use, which is going to the emergency room or primary care or getting surgery, that's an individual use of healthcare. And that's where people like myself as practitioners are often encountered. But public health recognizes the reality that our well-being often is interconnected. And so if I go to a restaurant and someone cooks poor food, I and the other 50 people there that day will be impacted by that. If I enter a space and someone is sick, with a preventable disease that could be prevented by a vaccine, and we haven't mandated vaccines, that person coughing and being ill in that public space will impact us collectively. So I think it's really important to localize public health and that word of the collective. It isn't the health of the individual, it's the health of a population and of the collective. And I think when we start to really embrace that, we start to understand why it's so important, just as Dr. Chapple mentioned, that we're thinking about it from the perspective of the governance of how we protect the health of this collective, because I can't sit in my house and kind of decree things. It has to come from a different governance body that's going to touch many of us. And it's sadly, I think that that's what is being resisted. And we can talk about why there is that resistance, right? If you think about this country's history of enslavement and genocide, there's often a real resistance to doing things as a collective because we don't see ourselves as a collective a lot of times. We see ourselves as, white groups and Black groups and Native American groups, and we see ourselves kind of as divided. And I think public health really starts to push against that tendency to divide and really starts to say, how are we thinking of ourselves as a collective? And when that isn't done well, we start to see the breakdowns, I think, in public health care delivery.
Great. Dr. Furr-Holden?
Yeah, I echo everything that was said. And I wanted to add just a little something to what you said about racism, because when we talk about racism, and I hope we can talk about it, because a lot of times, and I hear people do this all the time, and I'm just like, I'm trying to be patient, but I'm like, y'all got to get this better. People talk about race as a social determinant of health. And I'm like, race is not a social determinant of health. There's nothing inherently deleterious to my health about being Black. What being Black does is give way to experiences of racism, and it's racism and the experiences of racism and the sequelae and the legacy impacts of racism that impacts my health. But there's nothing about race, it's racism. And I want to just underscore that it is, it's perpetuated by systems and structures. It's baked in. Racism was baked into our society. White supremacy was baked into our society. The notion that there's a hierarchy on the value of human life and some lives are higher order than others was baked in. Do you know there in the Declaration of Independence, we the people did not include Black people. It didn't include Native Americans. It didn't include women. Black people back then were property and a fraction of a person. So those things are all baked in. And so this notion that we talk about racism as a public health crisis, I think acknowledges the fact that just as public health gets embedded and then operationalized through government, so does racism. And we can actually use many of the same approaches that we use in public health and for disease eradication to treat this disease that's baked into our society and our government and every system and structure, which is the confluence of racism and the underlying moral and value of white supremacy. But racism as a public health crisis, I think, is acknowledging not that public health is the origins of the disease or the origins of racism, but rather it exerts a big impact and influence on the health of populations, and that there are real public health tools and approaches that we can employ that will help us to remedy and maybe even eradicate this problem.
Agreed. So agreed that oftentimes when at least even in public health or in research or in practice, they often talk about, groups of people through a race lens. But when they're talking about determinants, it is this group is different than this group. When we're talking about equity, the question is, why did that happen? And the why is often not having access to resources. And it's a structural issue. It's a historical issue. It is trying to get access to resources and sometimes entire areas getting bombed, when you had resources in the United States. And all these different things, these are historical, they come up again and again. And so it's not a one-time thing. It is hundreds of years in the making. And agreed that it is engineered, it is baked in, and that's something that we need to think about. And when we're talking about COVID in this conversation about COVID, how has it impacted or affected Black communities that you are involved in, working with, especially when thinking about it from an equity lens? Like, how is this happening? How are we seeing these quote unquote disparities, or rather inequities in Black communities?
I think we've seen it at all points of this pandemic. So when the pandemic first hit, there was a real question in New York, because you can break New York down by these zip codes and you can kind of color code where we're having the most COVID cases. And we found that they were in the neighborhoods that had some of the lowest, some of the highest level of service workers, highest rent burdens, and the highest number of historically minoritized populations. And when they started to really push it and question why, it was clear that, the public health messaging of, if you get sick, separate out from other individuals, couldn't happen for certain people, or stay home and shelter in place couldn't happen if you had two jobs that you were required to get to in order to keep your living. And so exactly that comment of the social determinants of health was at play there, and it happens to impact certain racial and ethnic groups more. Now, I don't know if folks remember, but in the beginning, there were some articles that came out that considered whether COVID was spread more among Black and Brown populations because of some genetic reason. And I was really glad to see advocates and scholars and practitioners push back against that and say, no, don't take the lazy biologic explanation, which we have done historically from eugenics time onward. Let's really evaluate what is going on in these populations that's leading to this. And then, of course, we know from the point where, we moved from everyone being kind of, unawares of how to take care of COVID to even when we started to get treatments. There's research now that show that even in the hospital, racial and ethnic minoritized groups tend to get access to life-saving treatments at a lower rate than white populations. And when we move from inpatient to outpatient, all the new therapies that are now available, who is getting access to monoclonal antibodies, more or less? I think a study came out that said that Hispanic individuals have a 58% lower chance of getting access to monoclonal antibodies. Again, this isn't because of their race. This isn't because of something that they're showing up and doing. Clearly, there are structural inequities. And then, I think we'll talk about this a lot, but the data around the vaccines and, when vaccines were rolled out, we saw in communities where certain individuals who didn't live in those communities were coming in and getting at the front of the line to get access to vaccines. I think COVID has been one of the greatest examples that we have had in medicine of what we mean when we say that racism is the dearth, right? Racism is the problem, because COVID has come to really show us in a very short amount of time, in a very captive way, where all of us are seeing these same data of what it means to have unequal access to healthcare, what it means when you get, into the healthcare system to have people take care of you differentially, and all of the things that we've been talking about for decades. COVID has really come to kind of highlight, and I think you can see it from the start of the pandemic, even to now going into 3 years.
I want to give an amen to Dr. Safo for that real great breakdown. And I want to add just a couple of things to what you said, a little nuance from Michigan. So in Michigan, we were one of the first states to transparently report the disparities that we saw in COVID cases and deaths. I think Illinois might have been first, and Michigan and Louisiana within a day or so. Within like 2 days, these three states all came out. And lo and behold, African Americans in Michigan were 14% of the population, but they were 41% of COVID cases and a little bit more, higher percentage of COVID deaths. And I always, when people put those kinds of numbers out, like Dr. Safo said, people are quick to try to go to some biological explanation. But there is really just no biological plausibility for why that would be. So I'm a data person, I'm an epidemiologist. I said, let's look and see what data actually tell us. And what we actually found out was about half of that disparity could be accounted for solely through employment-based exposure. And I love how she was sort of framing that out for us and describing these different, types of occupations and service workers. We came up with this really cute term during COVID called essential workers. Prior to COVID, we had never described your Uber driver, the person working at the bagging your food at the grocery store, the orderly at the hospital. We've never called these people essential. We've never treated them as essential. Their pay does not signify essential. The benefits that they get don't signify that they're essential. And what we know, because of racism, because of the longstanding legacy impact of something baked into our society to keep certain groups, namely minorities specifically, down, Black and brown people are overrepresented in these high demand, low wage jobs. So this tone deaf recommendation that came out early on called just work from home, shelter in place. How do you do Uber from Zoom? How do you clean a building or a facility from home? It was a tone deaf recommendation. And in Michigan, I'm proud to say that we were the only state that I know of that actually closed the racial disparities gap. For African Americans, we did it earlier. It was that we could get those problems identified. It took a little bit longer for our Latin population because it's a much more heterogeneous group. Some are undocumented. It took more work, but we were able to do that. But it's because we created solutions that match the level of the problem. We didn't go to that biological explanation. We didn't do what we normally do, and people are quick to do it. They'll start blaming the disparate populations for their own outcomes. Well, they just don't want to stay home. It's like, are you kidding me? Who wouldn't have in the beginning, right? If we had known it would be 2 years, maybe we all would have had a different experience of it. But who wouldn't want to just sit home and be able to take that time and get your full paycheck and all of that? But when you're overrepresented in high demand, low wage jobs that don't come with paid time off, we couldn't even get Black and brown people a paid day off to get their COVID vaccine. So I just want to echo what she says. And I'll tell you something that I describe about COVID, because COVID didn't create the inequity. COVID shined a light on it. I say COVID was the snitch. COVID participated in the conspiracy, because to be the snitch, you got to be in on the conspiracy too, right? If you're not a part of the conspiracy, you can't be the snitch, because COVID really did shine the light on all of the massive inequities that we have and the systematic and structural deficits that we have that impact all people. And I'll say this just because it's not just exclusively a Black and brown problem. Black people, brown people, people of African heritage, people of Hispanic heritage are very overrepresented. And I don't want to get away from that. And I don't want to dilute things and call it something that it's not. But we see very similar disparities and a lot of intersectionality when you look at people with chronic disabilities, when you go into rural communities, we're talking about people who are uninsured and underinsured. And then the intersectionality of race with those factors is synergistic. So the combined effect of those is much greater than the sum of them individually.
Definitely have to take intersectionality into account with these various oppressive systems in place. It is a multiplicative effect, not an additive one. And so really thinking about, we haven't really talked about geography that much, but really thinking about that rural area. And sometimes people think of rurality as a very white space, but living in North Carolina, rural areas are very diverse. We have a large Black population living in rural spaces. And so asking them to go to a hospital, which often when we talk about healthcare, when we talk about public health, people really only think about it in the healthcare side of things, not in what you need to do before we even step foot in a healthcare system. It's just not feasible. But I wanted to make sure I had room for Dr. Chapple to provide any comments as well.
These ladies are amazing, and yes to everything that was said. The one thing I would just want to add is that at that point of the pandemic, when it was clear that there were racial disparities, I was working at the federal government level, and I can clearly recall the press conference around it, where Dr. Fauci and President Trump were talking about the racial disparity. And what I know is that the approach to the pandemic quickly shifted after that. The narrative shifted. Um, the urgency shifted. Once it looked like it was minority people that were mainly impacted by this, the national approach shifted. And I think that that's something that we see often, is that anytime a disease starts to look like, or a concern starts to look like, oh, this really impacts just minority people or mainly minority people, then it's like, well, do we really have to put all our resources into this? Do we really have to, continue to do all the hard work that we've been doing around this to slow this down? Isn't it really something that's intrinsically, their problem and not our national problem? And so I think that that was one of the major shifts that we don't really talk about, is kind of the policy perspective, the things that started to change. That was like March of 2020. And then almost really quickly after that, it was, let's reopen the country by Easter, right? So it's like, okay, what just happened here? And then another thing is that when we can talk about those people who were mainly impacted by the virus, but then we look a few months later and see who is prioritized for the vaccines. So it's like, okay, essential workers are restaurant workers, are cooks, are grocery store people. But when it came time to prioritize people for the vaccine, they weren't the top of the list for priorities. And so it really becomes like, um, it really becomes clear that those people who are impacted, those people who we called essential, are essential for who, for what, in order to keep happening, right? They're essential for the economy to continue to going, but they're not essential enough for us to decide to put all of our concentration into vaccinating them. They're not essential enough for us to put our efforts into squishing any kind of concerns or fears that they have about the vaccine. That's not the approach that we took when it came down to who we're going to vaccinate and who we're going to vaccinate first. So over and over again, our policies just perpetuated this disparity that we're seeing. And it's something that happens in our country time and time again.
You're absolutely right. And I remember also seeing that shift really quickly, of when they thought that it really impacted more white communities, COVID, in the first month or so. And then when there was that shift, I was like, well, we know where this is going. And it did go that way. But also this decision, or this narrative of like, well, what is good for the public's health is not good for the economy, where I'm like, no, what is good for the public's health is good for the economy. And we still have this, like, we're going to close, and like, when have we closed? I don't really know when things close. So this close, reopen, I'm like, these words that are used are not actually reflective of the reality in which things are moving in. But all of you have mentioned just how disparate what the COVID response is currently, but I wanted to kind of understand from your perspectives and your expertise, what would an equity focused response look like? If we could go from now on, I mean, would it be great if we're like from March 2020, and we're getting close to the anniversary. I do want to acknowledge that the anniversary of COVID is coming up in March of 2022, so in a few weeks. And so, like, if we could, I mean, you could choose, if you want to go back in time, let us know if that's your pinpoint, or from here on out, what would an equity focused approach look like based on your expertise?
I promise I will hand it back to Dr. Chapple. I'm gonna say one thing, that we needed real equity experts, and we still continue to miss that ball. Literally, nobody would walk into a hospital with your partner and just let any doctor in the building or any staff person or anybody in scrubs deliver your baby. You would want to make sure you were in the OBGYN ward, that you had the best in the hospital, especially if it was a high-risk pregnancy. But when it comes to the issue of equity, people think that their well-meaning, good intentions, bright ideas are somehow sufficient. And I can tell you, a lot of this hubris that anybody can do equity, because it's just not, there's no real science behind it, or there's no real evidence behind it. When people talk about the equity lens or being equity centered, people have spent their entire careers, and I'm not talking about healthcare equity, I'm talking about equity, like having it down in your bone marrow. I'll give you a quick example of what they did in Michigan. So if I could only do one thing, I would say have real equity experts leading the charge and making the decisions. In Michigan, and I'm not picking on Michigan, a lot of states did this. I can name other examples, but I work in Michigan, so I'm just going to use an example. In Michigan, when they were trying to get the vaccine out initially, and it's funny because we got a big missing data problem, but it's not an infrastructure problem, because the original criteria for who was eligible included age and occupation. Guess what? They collected the age data on our initial first 4 million or so doses. Less than 0.5% were missing age. So clearly we have the capacity to collect this data. Why they do that? Because they wanted to demonstrate that they were giving it to the people who were supposed to be getting it, right? Because if you didn't do that, the feds would not give you any. They would cut your supply. But 44% of the data were missing race, and 70% of it was missing ethnicity. It's the same system where you enter that. So you put gender, and less than 1% was missing gender. So we have the capacity to collect demographics, but somehow there was this big breakdown with collecting the race data and then putting it in. So then our state legislature said, we're going to prioritize distribution to communities that have higher proportions of older adults. And I said, well, that's not equity driven. They said it is, because older people are at greater risk for COVID and older people are at greater risk for death. I do the numbers down by race. The average age of death and hospitalization for COVID patients, if you're Black, is substantially lower. And if you prioritize communities that have disproportionately high numbers of 65-year-olds and above, you are prioritizing white communities, because living to past 65 is embedded in privilege. So you're now going to prioritize high privilege white communities for distribution. And people were like, oh, and I'm like, this is the problem. You're not equity centered. You're not steeped in the work. You're smart and you're well-meaning, but it's like that Dunning-Kruger effect. People think that they know a lot more about equity than they really do. And these are the people that got the mic and that hold the cards and that are making the decisions. And a lot of what they've done, albeit well-meaning, actually only furthered inequity.
Every week I tweeted, there is nothing equitable about our vaccination approach. And that is exactly why. Centering, not even looking at age distributions by race of who's dying was the number one flaw of our approach, because we would have clearly seen that for minority people that age was lower than 65. And we could have definitely taken an approach that centered people by race and age in order to get the vaccine out. So yes to everything that you just said. And then the one thing I would add for kind of going forward is that we need to still look at that same data. We need to see who's vaccinated. We need to see who's not. We need to see what areas, what concerns, on and on. And we, looking at that data, would clearly tell us that we are not at the place that we need to be in order to take away mitigations. And that would be the thing that we need to do. Know that we have to take an equitable approach to mitigations. We need to keep masks on. We need to keep rules and regulations around social distancing. We need to do all these things because we have large segments of the population who have, while they may have had the opportunity, they haven't had the education, the time and space that they need in order to make that decision and to get vaccinated. And until we put our public health efforts into making sure that we are reaching those people, instead of just telling people what to do, we need to be able to reach them, help them understand, help make decisions. Until we can do all of that, then we're not at the place where we're ready to take away the protections that we have as a society to keep them safe.
I think it's so well said. The one thing that I would add is, part of the reason why these equity discussions get kind of difficult is that exactly, I think as has been said, people don't fully know what they're doing. And so without examples, people are kind of wringing their hands, if you will. And one of the things that I think would be so powerful is to start to do, I think, what a lot of equity experts say we should do, which is to prioritize the people that are most at risk. And so we started to kind of think about doing this, for example, when we were rolling out Paxlovid. A couple of states said for Paxlovid, it's a limited resource. Paxlovid is the antiviral that we use if you have COVID and you're mild to moderate risk of progression, that you can get it within the first 3 days, and it really helps to prevent you from getting severe COVID. Game changing, could be amazing. So a couple of states said when Paxlovid is being rolled out, please indicate the race of the individual, you as a clinician, that you're trying to get this medication for, because we'd like to prioritize those from racial and ethnic, historically minoritized groups. And, you know, there's such power in this, because think about it. When do you see Black and brown people going to the front of the line, right? What you see a lot of times is you see a lot of research and data and conversation about the epi and how messed up it is, and shouldn't we do something, and wouldn't it be nice if we did? But there are now people who are pushing. Dr. Michelle Morris and Bram Whispery did this really incredible study program over at Brigham, where they said historically our cardiovascular service unit has tended to have more white patients get access to this life-saving resource. We propose that we actually put Black people at the front of the line, right? That is not a difficult thing to think about and to do. When you think about the fact that these racialized structures are built on these inequities, and these inequities benefit one group, they tend to benefit white Americans, then if you're serious about an equity-centered approach, you're going to start to think about pushing on prioritizing certain groups that are high risk. And so, I think about these examples, the Paxlovid example and others, as being so important, because when one state sees another state doing that and doing it successfully, they're more willing. Now, what's so interesting about, the Paxlovid story is that a few states that did this in the Midwest primarily were attacked by bigots and white supremacists who basically reframed it as saying that by prioritizing race for historical minoritized populations, that white populations are actually being treated poorly. And I just think it's fascinating when you get to these spaces where people say, basically what they're saying is, we don't want to be treated like Black people are treated. We don't want to go to the back of the line. We want to continue to be at the front of the line. And yet equity says, if you have groups that are very, very, very differently placed, you have to start to put them on the same level so that we can all move forward. And that's the only way that it works. And, I love this idea of COVID is the snitch is going to stay in my head, because COVID is the snitch, but it's also, I think in some ways, the great revealer. And there's so much that we can learn from COVID. There's so much that we can learn in terms of how to do this better and right. And, I would say, if we're thinking about a true equity approach, get the examples out there where you've prioritized the groups that are historically disadvantaged. And every time a white supremacist group wants to clap back and say, this isn't fair, our voices should all be lifted up. The counter protest should be even louder. And we should say, this is actually fair. This is righting. This is reparations. This is righting the wrong that this country, essentially has been founded on. And we're going to keep pushing until we get it right. But that takes all of us continuing and pushing and striving. And I know I'm tired, and I know we are all tired, but really COVID has set us up to be able to really make, I think, some really, really big impact, and to show that healthcare can be done in a different way.
Can I add one thing to that? Because I love what you, and I said this, I've been telling everybody COVID's the snitch, because that's how I talk. That's what makes sense for me. It's very authentic coming out of my mouth. And somebody else said, I don't feel comfortable saying it's a snitch. I feel like COVID gave us the revelation. So they too call it the great revealer. So Dr. Safo, with your grace and elegance and all those people that you will touch in the healthcare space, and Dr. Chapple and all those people that you will touch in government, I think it's important that, and you hit it right on the head in my opinion, that we provide salient examples for people so that they can understand that this is something that there really is expertise that exists in it. There's a grounding in it and a steeping in it. And that if people were willing to have enough humility and enough, just acceptance that you don't know everything, right? And MD doesn't make, Dr. Fauci literally walked around, in my opinion, during this pandemic with his chest popped out like end all be all. When the former administration changed, and, before that, his kind of shoulders were down, and he was like, and then I feel like the day after the new administration came in, he had like a new zep to his step. I almost felt like he should have theme music behind him, like walkthrough should be playing when he entered into the room, because that's how he walked around. But then I look at some of the things he said and done since then, and I haven't really seen that radical shift. And I realize it's because they're really not giving the credence to the real expertise in it. And I think it points to something that Dr. Chapple was saying about having these, just at a basic level, public health people embedded into all of these different places in government and places in the community where these decisions are being made. It somewhere 10, 15, 20% of health departments, depending on where you are across the country, have nobody with a public health credential working in them. Not even an MPH, not even just a trained public health practitioner. So then when we try to go that whole extra step and talk about equity, it's like we have public health departments that don't have anybody with public health training. Now, don't get me wrong. I'm not saying that these people don't have extensive experience, right? And on the ground floor experience. But again, do you want to leave the health of your community in the hands of people who are well-meaning or people who are well-trained and well-meaning? I think we could have it be a both and not an either or. So the second thing I think we need, in addition to experts, is that training and that pipeline to get people the training. Where are the Gillings schools and the Hopkins and the Harvards? And then let's go all over the map too. I'm not saying go down, I'm just saying go in different dimensions, because HBCUs and minority serving institutions are also birthing a lot of these great scholars. We don't quite give them the credence that they deserve. And I don't just mean the Morehouses and the Meharries. I'm in Virginia right now. I'm talking about the Norfolk states that has a pretty potent Center for Health Disparities, but they can't get in that NIH pipeline because that glass door and ceiling, it's like a glass box around them, still exists. But if we could get them more skin in the game and deal with equity in those spaces too, we could also do a better job of training and seeding the next generation of scholars. So we're not caught off guard for the next great pandemic or round of health, equity oriented challenges.
We can have a whole conversation about inequities of training and funding in the public health space, but I agree with everything. Dr. Chapple, do you have anything else you want to add?
I was just going to make a plug for state and local health departments. So right now, only 17% of people who work in state and local health departments are trained in public health. So public health people listening, please come to state and local health departments. We are on the ground doing the work. We need that equity lens. We need that training, that education to come and really make changes in local health departments. So just a plug.
Yeah, one of my really good friends is the public health department in her rural town, the one epidemiologist. And so it's a lot on her to manage in a rural space. So, but yes, I agree with all these points. The one thing I would add was pulling that communications, because it's been all over the place. Being in spaces with Black communities, one thing we've been talking about is I don't know where to get information that I trust, because I'm told one thing one day, another thing another day, with no explanation in between of how did they get there. And it could be data driven, but you need to explain what that is too. People are owed an explanation of how you got to your conclusion, like kind of show the work. And I think it's fair, especially because I don't even understand some of the things, and I get called by every member of my family to interpret things. And I'm like, I don't know. So I'm going to have to look it up too.
We do have this area of expertise called health communications. None of them have been aged.
No.
From the naming this whole vaccine push, Operation Warp Speed, undergraduate health communications major could have said, that's a bad idea. Do you want something injected in your body that was made at warp speed? Some people said, we talked to people in community, we did surveys. What do you hear when you hear warp speed? They said, it makes me think of Star Trek when the ship they go into warp speed and then it take off real fast. Some people say, I heard quick and dirty. That when they heard warp speed, they heard quick and dirty. Other people say, I heard corner cutting. I heard skip steps. So again, we haven't engaged experts, but you get a bunch of arrogant white privileged men in positions of power around the table, and they're making decisions. Jill Perm was head of Operation Warp Speed. Dr. Slawi was the chief medical officer. Dr. Fauci was in the room, you know, chiming in how he was chiming in. Francis Collins, who's done, you know, some might argue, you know, some transformative work and definitely is leaving a better legacy than as he's on his way out than when he came in, you know, setting up the Common Fund. He's put some key leaders and some really strong minority leaders. And it's not, these aren't token placements. These are people who are very strong running these, you know, programs, you know, so it's like, but where were the health communicators when all this stuff was being named and framed and rolled out? Where are they now to help with the messaging? When this vaccine first came out, you can say whatever you want. I've taken the CDC changed so much. If I see something on their page, I would screenshot it and I would save the file. It's roughly what it was, because 3 hours later, the stuff might be gone. Like it literally might be gone. So where are the people who are helping to explain? Because people feel betrayed. They said when the vaccine first came out, you told us this would stop us from getting COVID. Now you're saying it'll stop us from getting severely sick from COVID. Then the CDC changed the definition of a vaccine so that the COVID vaccine could technically still be the vaccine. And people don't get no explanation around that, but they have these goalposts of information, and then they fall in the trough of misinformation in between the goalposts of information that they have. And we've not engaged health communications and health communicators in the work of helping us get this translated. And we've devalued the voice of the trusted, credible local messenger. And to back Dr. Chapple up, for some people, that is their local health department. And if it's not, what's the work that we need to do so that it can be that? Because I would offer that what's happening in your local health department is much more impactful to you than what's happening in the White House, or maybe even than what's happening at NIH. You know, so I just think these are things that we've all got to sort of consider. And again, I always go back to who are the right experts to engage in a legitimate transdisciplinary multi-sector partnership to solve a global pandemic. We're not talking about a little flu outbreak in one town. We are dealing with a worldwide epidemic. And we have fared a lot worse than many of our peer nations, even though we have more resources. So clearly we can't just throw money at these problems.
One question that I would get a lot from Black people in communities that I speak to is, why is the government interested in us now? Why do they want to promote the vaccine to us now? The government hasn't shown interest in us, you know, outside of incarceration. So what is the push? Why would I do this? Especially being government voices are the ones that I'm hearing telling me to take this vaccine. So back to that, to the things that we know, right? We didn't employ the things that we know in the rollout of this vaccine. We definitely know that the way to deal with behavior change is to go through trusted messengers, but that's not what we did. We, you know, put a few people on the news, showed them getting vaccinated, told people to go get vaccinated now. We told them we're going to put vaccination sites in your community, now go, right? But what did we do to help them? What did we do to answer questions? What did we do to address any of those things, like that the information has changed, that our knowledge has changed? We didn't do any of it. We didn't draw any of those lines. We didn't close any of those loops. And I think what's really important is every time that I went into communities, I stood up and said, this is what I know and this is what I don't know. The virus is novel. I'm not going to know everything. No one should be expected to know everything about this. But let me take you through what I know. Let me take you through what has changed. Let me take you through what we thought. Let me take you through why that wasn't right. You know, like, people truly appreciate when you come at them with real information, and that you really, you know, walk them through why you're important, why we're doing this, why we need you to come along and come on board. But that has really not happened outside of individuals who look like me, who have drive that I do and the love that we have for our community, you know, but there was no national approach to this. There was no payment for this. This was hard work. And this is what we needed to have nationalized, right? Biden came in and said he was going to give us 100,000 community health workers. What happened to those? That's what we need in our communities in order to really try and get to an equitable approach.
And I would just add, like, I think one thing that, we're all kind of suggesting here is that these lessons shouldn't be lost on us. Unfortunately, because of climate change and some of the other struggles that we're going to face as mankind, we will have another pandemic, and it will probably be worse than COVID. And so if you think about COVID as this kind of first group project that we're doing together, and you give us a grading, this is the easy version of the test. And I think we failed it. And I think the million lives that we've lost in this country alone will absolutely tell you that. And yet, I really, and this is the very strange part of being a New Yorker, because I still am optimistic. This is the optimist in me. I think that there's a ton that we can learn from this, and a ton that we should carry forward. And one of the biggest lessons was, mentioned by both Dr. Furr-Holden and Dr. Chapple, which is that we are working from a history when we think about approaching different populations. And that history is one that is well founded on distrust. And that is appropriately founded on distrust. If you, take a population that you basically screwed over for over 250 years, and then suddenly turn around and say, I have this great thing for you, and I'll pay you to get it, which we did in a lot of places, of course, individuals will be doubtful. And so what I see going forward as being really important is building or not just even primary care, but building a healthcare infrastructure where you really center the voices of those who are most likely to suffer poor consequences when you don't get it right. So what does that look like? It's our community, our trusted messengers, community health workers. It's making sure that at the tables that has, Fauci and Zientis and others, that you also have people who actually live real lives in these communities. And, I think COVID will give us a respite at some point for us to prepare for the next pandemic. And that preparation really has to center people who look very different than the people who get up on TV and tell you what's coming next. And that will take humility. And I don't know if, many of the people who are decision makers are ready to do that, but that'll be the only way that we're successful when we have the next iteration of COVID that, unfortunately, as I said, I think will be much more severe.
Yeah. So thank you all for kind of your insights and your expertise in all of this, and what we have failed to do and continue to fail to do is not bring in the multidisciplinarity of public health to address this issue. We could bring in public works to help us with buildings and ventilation, things that we should be doing to prevent transmission, but we have not done that. But as we're wrapping up, I want to really acknowledge that COVID has exacerbated these physical burdens and caused mass disability for millions of people in the form of long COVID, and also mental health burdens. And so kind of thinking about how do we in communities kind of create that space for processing what we're dealing with in real time. I don't think we've really given ourselves the ability to grieve people, grieve what we had, the life we've had, the people we were even. Sound very like a therapist right now, I'm not. But also kind of also think about what we're going to see with long COVID and disability. And I don't believe that the governments from the local to the federal level are prepared to help people to manage these conditions. I've done work in Zika, which was an epidemic. And one of the things I remember hearing from moms who had children with microcephaly was, we got money for this acute issue of maybe getting our children to physical therapy or different things like that. When the money runs out from USAID, what are we going to do? Most of the women, most of the families were in poor areas, in rural places. They had to go to urban centers, and they're like, we've been completely forgotten. And we have kids who are going to grow up. Right now I can hold them. They are a year old, maybe 2. It's not gonna be like this forever. And so I'm seeing the same thing happening with, we are in the process of not really doing the work to really think about the people who are currently or maybe getting long COVID or long COVID type symptoms in the long term. So I wanted to hear from you all about that before we wrap up.
At the start of the pandemic, I was really disillusioned. I thought that this was going to be the thing that really drove equitable approaches. I thought this was going to be the thing that drove universal health care, that we would really start to realize that the health of your neighbor impacts you and your health. I had no idea that it would take this turn to be more individualistic than what we had when we started. And so with that in mind, I fear what's to come in terms of the number of chronic diseases that we'll see in the future and how that'll impact our longevity and our, quality of life moving forward, and how people will decide that they don't care about the impacts that this has on community health and overall health. And so I really do hope that people have a better answer than that, because right now I just have concern.
The one thing I'll say, and I'm gonna make this my last point because I think we're about to be out of time, is that equity is a very weak muscle for our nation. It just is. It's like, think of it, equity as like Bambi legs for us. It's just a weak muscle. It's nothing that we've ever, held up as a value, nothing that we've ever really, put forward as a value. And so now people talk about it, it's almost become like a buzzword, but it's still a weak muscle. I remain unrelenting and unapologetic about being in the fight for and standing bold in the front line with many others. And I just really appreciate the opportunity to be with you all and have this conversation in the fight for it. But I'm also not so arrogant or so young that I believe I'm entitled to have that right at this very second. I'm fighting for right now. But it is a weak muscle, and it's something that we're going to have to build up over time. And this issue around long COVID, it doesn't really surprise me because, a lot of the people at greatest risk for long COVID go back to this notion that we live in a society where there's a hierarchy on the value of human life. We've never treated people with disability, with chronic health conditions, as if they really were the most precious in our society. And so now we're going to have to end up paying the price for that. And the thing that I find really interesting about it is equity costs us all. There's actually a business case for equity, and there's a cost for inequity, but then there's also a cost to the individual, because you don't know what future surgeon, what future change maker, what future inventor is not here because of COVID. What child got orphaned and now their potential has changed because they've been orphaned during COVID. So these problems have a long impact, a long-term cost for all of us. And the issue around long COVID and many of the sequelae of COVID, we do need more ongoing research to look at these issues. So I hope that we can see those investments so that we can try to mediate and mitigate some of those impacts. Thank you so much.
And I will just add, as a practitioner, seeing patients, I take care of patients who have HIV and I do primary care. Long COVID is going to be decimating to Black and Brown populations because long COVID often presents as symptoms that can be excused as psychosomatic. It's much harder in the Zika example, to deny that a baby has microcephaly, right? It's easy to say, oh, that fatigue you're feeling, that brain fog, that's just, do you smoke some marijuana? It must be the marijuana. Whatever assumptions or things will be said. And we know that healthcare delivery is incredibly racist. All you have to do is look up recent stories of Susan Moore, a woman who died of COVID as a healthcare provider, even when she was calling for better care. And so if you think about the people who are going to be accessing the system and the symptoms they're going to be accessing the system, these racist systems with, we should all be very concerned about how these populations, how our populations are going to be treated with long COVID. And I would say one solution for that is it has to be ground up. These systems are never going to save us. No one is coming to save us. It's going to be us saving ourselves. And I really, really believe that individuals are going to have to band together and share in patient advisory groups and patient kind of support groups what's happening. They're going to have to push really hard when they encounter physicians that are being discriminatory and not listening, to really make sure that they're able to get their voices heard. And this is just yet another thing that we're adding to populations that are already super taxed. But I don't see the healthcare system treating long COVID appropriately as it should, especially in historically minoritized populations. And I hate to leave it on that negative note, but I think we have seen this script many times over, and we know how this is going to go.
Yeah, I mean, although we see that this is happening, we also all collectively can have the power to advocate for things like federal funds, maybe changing how, well, private health insurance companies could be different, but at the federal level, what can qualify for disability, all those different things. There's a lot of hoops. As someone who has family members who've applied for federal disability, it is a lot of paperwork. It is a lot of time. It is a lot of back and forth. It's a lot of, you need to have everything on record. So ways to minimize that, because that alone is really difficult for individuals. That alone is a stressor, just to try to even have people acknowledge the fact that you know that you're not feeling the way you used to. And I think one of those ways is really, working collectively to work on those changes to reduce those barriers. But I know we're kind
Dr.
of—
Wallace, can I just have 10 seconds for one thing?
Yes,
I
go
just
ahead.
want to do a plug for the hashtag urgency of equity. These amazing, brilliant equity warriors, just world-class scholars, have put together an equity toolkit called the urgency of equity. If you follow that hashtag on Twitter, toolkit is coming any day now. I think it'll be something that people will find very useful. And I think it's something that if we can continue to build it out and make it better, we'll be able to gain a lot of traction, maybe garner the attention of people who are making decisions, who are distributing resources. So just a little plug for hashtag urgency of equity.
Okay, follow the hashtag. Dr. Safo says it's coming out today. Also follow our sponsor, Marked by COVID, which is a grassroots organization founded by individuals who are affected by the COVID pandemic, and also really lift up individuals. They're working on a COVID memorial now that March kind of is the anniversary of when COVID really kind of came through in the United States side of things. So again, kind of talking about ways that we can memorialize and really hold space for what we've gone through in that way, and also make sure that the federal or state governments really acknowledge that. I know there was one question in the chat, and I'm sorry we couldn't. It was about the ACIP, the way the ACIP backed off its original plan to prioritize essential workers for vaccines. Does anyone? I'll give it a minute. Does anyone have any kind of? I don't know much about that, but Dr. Chapple, Dr. Safo, Dr. Furr-Holden, do you know anything about the way that ACIP backed off its original plan to prioritize essential workers for vaccines, largely because that plan would have resulted in more deaths among the elderly, including Black elderly? I don't know if we have any.
That feels honestly like a little bit of a trap, something that needs to get unpacked a little bit better over time.
Yeah.
Here's what I'll tell you. If we had prioritized essential workers and elderly with some nuance for age by race in community, we would have had plenty of vaccine early on for everybody and could have avoided a lot of death and disability. The inequity overall in the overall vaccine rollout strategy left a lot of people now with the attitude, why bother? And so I don't believe, I've not seen anything empirically that substantiates if we had prioritized essential workers and done a better job of ensuring that the people who were eligible actually were the ones getting shots in arms, that we would have had any additional death or disability. So that's the short answer there.
Well,
Yeah.
Thank you, everyone. And
Thank you so much for having us.
Yes, thank you for the hour. And I hope everyone has a good day. And we hope to see you at one of our next events.
Thank you so much.
Thank you.